Hello everyone. Welcome to another Wednesday morning report. We're very excited for today's case. We uh, mainly because the discussants today are Robbie and Maddie, our fearless leaders across the CP Solvers community. We're very excited to watch their discussion. Uh, Tansu will be presenting, and we have a very special guest with us today. Tansu, I'm gonna hand it over to you to maybe introduce yourself and uh, maybe popcorn it to someone else after.
Thank you so much for being here today, friends. My name is Tansu. I'm an international medical graduate from Turkey, and I'm very excited for today's special case and special VMR. I'll pass the mic to Maddie to introduce herself.
All right. Hey, everyone. I'm Maddie. I'm part of CP Solvers leadership, and I'm currently a fourth-year medical student in New York. And I'm really excited for the session. I am very excited that Mr. Berg is here and just excited to discuss with Robbie. It's always so much fun. I guess I will popcorn to Robbie.
Hi there. Good morning, everyone, or good noon, good afternoon. My name is Rabih. I'm also one of the CP Solvers team members. What's so exciting about today is that I see so many videos on and so many people who are generous enough, not just with their time, but also with their space. It makes it so much more bright in here. So thank you. It's a thrill to be here. I am a last-minute substitute for Dr. Jack Penner, who could not make it today for work reasons. These are massive shoes to fill, and I'm excited to wobble with Maddie today.
We're very excited. Tansu, if you're ready, and Gerardo, if you're ready, we can start with the case.
All right. When you are ready, Gerardo. So our patient today had 1 week history of fevers, fatigue, and 1 episode of profuse nosebleed. And I will just stop here.
Maddie, what thoughts crossed your mind?
All right. So 1 week history of fever, fatigue, and one episode of profuse nosebleed. So generally when I try to make progress on a chief concern, what's really important is knowing who the patient is. So what is the patient's age? What is their immune status? Really wanting to know who is the person in front of me, who I'm trying to kind of understand these symptoms from. So I'll be really interested to hear in future information a little bit more about this individual who's standing in front of me. But just to I think it's an interesting diagnostic challenge to try to think through a week of fever, fatigue, and profuse nosebleed just in general before knowing a little bit more about the patient. So for fever, I guess just to say for fever, fatigue, an episode of nosebleed, of all of those things, what I'm really focusing in on is really the profuse nosebleed and then also the fever, because those I think are a little bit more specific and will help me make a little bit more progress as to what's going on. And I'm looking at the fatigue kind of as a barometer of the severity of the current, I guess, disease process, if you will. So to talk a little bit more about the fever and the nosebleed. So the fever, I translate that into inflammation. And you often can think of we've talked about the IMAID mnemonic for fever. So inflammation, malignancy, autoimmune, drugs, endocrinopathy, and then you can add kind of a pulmonary embolism, which can have fever. I think with the time course here, which is 1 week, I generally with an acute, I feel like I'm labeling 1 week as more or less acute, kind of verging on the subacute. And that would cause me to prioritize something like an infection. And then to talk about the episode of profuse nosebleed, I think first wanting to kind of quantify a little bit of that, before jumping into the diagnostic aspect, is this something that I need to be thinking of management. I want to make sure the airway is protected. Do I need to think about positioning? And, I guess I'm concerned that did this happen all of a sudden, or have there been multiple episodes of profuse nose bleeding? And before diving in too much of that, some of the initial things that would cross my mind is there, if someone's bleeding, is there something wrong with the vessel? Is there something wrong with the patient's ability to form clots? Is there kind of an anatomic abnormality in the nose that's causing them to bleed? And then before narrowing in on that, I just want to make sure that this really is true, that the blood is coming from the nose and that we're not being fooled, maybe that it's coming from the mouth. I just really would want to clarify where the blood is coming from. So those are my initial thoughts, but for more information, really wanting to understand who is this person in front of me, what is the age, what is their medical history, and then wanting to understand when this all started. Did this all happen 1 week ago, or has there been more of a subacute to chronic, feeling unwell that is behind this? Rabih, what about you? What's going through your mind?
Oh, like you, Maddie, I'm so intrigued, and I think there's so many threads to pull on, and I have nothing to add to every single dimension you tugged on. But we'll just ask Yusuf and Tansu to help me manage how much profuse verbal diarrhea I have to. Tansu, maybe you could. Because I know that time is of the essence today. The plan for the discussion is 25 more minutes. Do you know how many more aliquots you have?
Yes, Rabih. So I have 5 aliquots, and in the 5 aliquot, I will reveal the final diagnosis.
Okay. All right. So I have 30 seconds now, and maybe like 3 to 4 minutes per aliquot. Okay. Yeah, Mehdi, I have nothing to add to your reflections. I'll just say that it is profoundly important to recognize that the patient is escalating the level of the epistaxis to the chief concern. And I will draw some inferences from the fact that this is in the chief concern to make the assumption that this is severe and probably new. Most people who have nose bleeding have nose bleeding seasonally and are so used to it that they probably would completely ignore its relevance in a clinical syndrome. So the very fact that this patient is choosing to utter these words very quickly and very upfront leads one to assume that it is a hectic part of the syndrome. As, again, I'll iterate, the base rate of epistaxis is one that the patient is often habituated to. So for me, that's why I'm deploying the schema for epistaxis, because the patient is signaling to me that I should. And that it begins with management, which we can reflect on if we see that on exam the bleeding is ongoing. But you're right. I think we've practiced fever and fatigue on VMR a lot. We haven't practiced epistaxis much. And so this will be an opportunity to do so. But I agree with you. It's probably signal, and it's probably part of this the syndrome, simply by the sheer fact that the patient is mentioning it up front, as opposed to a side review of systems observation. Alrighty, Tansu, tell us more, please.
All right, perfect. So our patient is a 15-year-old, previously healthy female, and she had a week-long history of fevers, fatigue, sore throat, and she also had an unusually prolonged nose bleeding that was unusual for her, which prompted her parents to brought her in to an urgent care clinic. And there, she was found to have a urinalysis that was notable for pyuria, and the culture subsequently grew more than 100,000 colony-forming units of pan-sensitive E. coli, and she was discharged on cephalexin. And then 2 days later, she presented to her pediatrician for a follow-up with chills, headache, abdominal cramps, nosebleed, and extreme fatigue, sore throat. And on physical exam, she was found to have a sharp right upper quadrant abdominal and flank pain that was worse on palpation during inspiration. And she rated it as 7 to 9 out of 10, and a milder left upper quadrant pain. And so there was a suspicion for the possibility of resistant bacterial UTI, and she was given an IM ceftriaxone and ciprofloxacin, and she was advised to present to the hospital for further evaluation. And then her past medical history is she doesn't have anything relevant. Her family history, there's no relevant family history. And she's just using the medications that was prescribed by the urgent care clinic and her pediatrician. And her social history includes no travels, no relevant social history, and she doesn't have any allergies. Her vitals, so I could only have access to her temperature. It was 38.9 Celsius. And unfortunately, I don't have access to the rest of the vitals. But I can tell you that her general exam showed a tired-looking, slender young girl who had general malaise. And all the systems, other than the abdominal exam, was within normal limits, but the abdominal exam revealed a right CVA tenderness and mild right upper quadrant pain and tenderness.
Hey, just to dance together for this case, I think one, I just want to acknowledge that this is a patient who's 15, and I think that as a adult physician, anything that at least I can reflect on with confidence is really just adjusting for this patient's age. She's close enough to 18 where I would be able to provide actual medical care. And I think acknowledging that I'm not an expert in this domain is really, really important. To do so. And so I think everything that we're going to talk about is probably it's probably tweaked for age. But I'm curious, when you just reflect on the first presentation of the symptom complex that she has and the diagnosis of a urinary tract infection, what were your thoughts at that point?
Yeah, so kind of what my thoughts were prior to getting the physical exam and the information about the abdominal. I think what stood out to me, I guess, especially hearing about the sore throat, and that is that this seemed to have some sort of systemic like fingerprint. And then I think the other thing is that when we got the information about the urinalysis with pyuria, I think some I guess some like a stop sign kind of went up in my mind of, I think it's what did the person have symptoms? The physicians were perhaps concerned about a urinary tract infection, but pyuria we know doesn't equal a urinary tract infection. So I think I was taking that with a grain of salt and just kind of recognizing that she had a urinalysis with pyuria. Is that signal, is that noise, is that very relevant to the kind of current presentation? But I think I was just noting that as not the main problem I was trying to solve.
Yeah, I completely agree with you. I think that, I think what you're seeing operate here is the power of the base rate. In young patients who are febrile, there are two infections that predominate, which is upper respiratory tract infections, bacterial, viral, and then urinary tract infections. And so when you see pyuria and a fever in a young adult, the diagnosis of pyelonephritis jumps to mind. And the question is, well, what happens to that diagnosis when you actually go talk to the patient and realize that no urinary symptoms are mentioned? And in fact, the main symptoms are fever, fatigue, and a pharyngitis. And that's when you really have to tweak your possibility and probability of a urinary tract infection and markedly reduce its probability. You might have listened to the RLR episode where we had a patient who had fever with no localizing symptoms, and we learned that that patient had pyelonephritis. So you don't have to have localizing symptoms to have pyelonephritis, especially in a young adult. But if there are symptoms of a distant organ, that's a whole different calculus. And I think when the patient doesn't improve with antibiotics is when you should call into question the diagnosis with an extensive amount of vigor. And so with that in mind, what's happening in your mind now with the additional abdominal dimension to this case?
Yeah, so the additional information we got was that there's both right CVA tenderness and right upper quadrant pain. And a few things crossed my mind, I guess to the point where there was also a recent RLR discussion that talked about CVA flank pain, basically, and how you have to be a little bit cautious of course, our mind jumps to the kidney. And because, there was this recent concern of a urinary tract infection, I think that is on my mind. Could this be an atypical presentation of pyelonephritis? The CVA is the region of the kidney, but also you have to recognize that there are so many structures in the flank area. And is this, probably not in this case, but could it be like back pain, like musculoskeletal? There's also the pleura that abuts that region. And I think I heard in the history that there was more pain with inhalation. So is there like a pleuritic component of this?
Awesome.
But yeah, I think that's actually the thing I'm most focused in on. Like, if this is fever and abdominal pain, both the right CVA tenderness and the right upper quadrant. And I think my mind is going through some of the do not miss causes.
Yeah.
And then also adding on to that, like, this is a 15-year-old female, of reproductive age. I think just wanting to get a pregnancy test, as that would really change our thinking and understand a little bit more of the sexual history.
I feel like you're more of an expert in the care of this the patient than I am. I think that was absolutely outstanding. Your pivot is completely moving, and you're like, this is an abdominal case. And I'll tell you that the diagnosis of pyelonephritis is called into question by the history that we just talked about. Then its probability is markedly reduced when the patient has bilateral abdominal complaints, and the patient is essentially the fact that there is left upper quadrant pain. So now we essentially have to start from scratch and say that this is essentially a febrile patient with symptoms from all the way in the throat to the abdomen, a systemic disease, as you already alluded to. And I think the value of left upper quadrant pain cannot be underemphasized. It is of enormous value. So I'll just list out the organs that we entertain in left upper quadrant pain, which is the left kidney, of course, the stomach, the colon, the distal pancreas, and the spleen. Now, which of those organs do you associate with a hematologic bleeding dimension? What do you think?
Spleen.
Yeah, there you go. I completely agree with you. I think that when you have left upper quadrant pain and epistaxis, it's not a good combination. I think that radically changes the case and makes me want to get a CBC so bad, analyze the CBC with a tremendous amount of detail and the peripheral smear. The real alarm flag, Maddie, is the complete absence of anything in the medical history. Remember what we talked about? This is base rate gone wrong twice, I think. This is base rate gone wrong with fever being assumed to be pyelo. It's a very good assumption to have with no information. But once you get more information, you got to question that. And the base rate gone wrong with epistaxis. The vast majority of people with benign causes of epistaxis have a long, protracted history of it. And the absence of anything in that bottom left corner has me really, really worried. Ordinarily, I'd love to reflect with you more, but why don't we pass the mic to Tansu to give us a little bit more information?
All right. So I will give you the first set of labs, and then I will stop for a brief period just to hear more of your thoughts. So we have a white blood cell count of 25,000, and 80% of which are lymphocytes. And hemoglobin is 11.9. Platelet count is 79,000. In the so we have an AST of 189, an ALT of 249, ALK phos of 393, GGT of 290, albumin of 2.5, total bilirubin is 7.2, direct bilirubin is 5.2, lipase is 406, amylase is 39, and repeat urine culture is negative. So I will just briefly pause here.
Maddie, I'm curious. You got a lot of data right there. I think there's sort of two dimensions to it. The first is maybe you can give us insight into your reflexes, reflexes into the data that alarmed you the most and the data that you find the most diagnostically specific. And those could be the same thing, but I think that's what we try to do in real life. We're like, what has me panicked? It could be the blood pressure of 80/60 in general, but the most specific data might be that the patient's BNP is super high, and that tells you it's the heart. So here, you mind shedding light on what you're zeroing in on diagnostically and then what you're zeroing in on in terms of illness severity?
Yeah. So I guess to answer the second part first, so kind of what stood out in terms of the severity and kind of just what jumped out to me. The first thing was the white count of 25,000 lymphocyte predominant. That stood out to me as very alarming. And I'll circle back to that, but I think that might also be most diagnostically helpful. And then the other thing that really stood out to me was the total bilirubin of 7 with a direct component. And not at those were basically the two things that really stood out to me as alarming. We're also seeing some hepatocellular and I think also cholestatic liver injury, but I think the main two things were the white count and the bilirubin, and then also the low platelets in the context of this profuse nosebleeding, and like could that, just basically just the low platelets being that explanation. So yeah, to answer your question, those are two things that stood out to me. What I think might be most diagnostically helpful is the elevated white count. Also in a recent RLR, you were talking about basically leukemias and wanting to categorize this as acute versus chronic, and then of myeloid or lymphoid lineage. And of course, with the 80% lymphocytes, I'm concerned that this is of lymphoid lineage. I'm concerned that this might also be acute, given that it seems like this all started about a week ago, and the patient was not, it seems like there wasn't too many symptoms she was reporting prior to that. So I think I'm really interested in a blood smear.
Superb. I agree with you on all fronts. And I just wanted to make a point to the audience that of how important it is to get that differential diagnosis, diff on the CBC. I think as you identified, Maddie, that's the crux of this case from a diagnostic perspective. It is so easy to overlook either ordering or studying the differential on the white blood cell count, but it is of paramount importance because the analysis of this case, if those were 80% neutrophils, would be so fundamentally different. And we've talked about this. This is funky inflammation. Funky is not at all a scientific term that should be used in outside gatherings like this where we know each other. But what it means is that most people have inflammation that is neutrophilic, and that neutrophilic inflammation rarely changes the differential diagnosis. Funky is meant to imply that the body's response is unusual, either lymphocytic or eosinophilic or basophilic or sometimes even more morbidly blastic. And studying the body's response is often more powerful than studying anything else. And the body is telling us the very specific response it is mounting is lymphocytic in nature. But as you said, you have to make sure that these lymphocytes, which are often automatically detected by the automatic smear detector, are actually lymphocytes. There are numerous case reports littered where blasts, monocytes, and other even more alarming reads are initially read as lymphocytes. So my first step would be to say, I know this is funky inflammation because these aren't neutrophils. And the question is, what is it? The automatic review of lymphocytes is pretty accurate, but I would not commit to this being a lymphocytic pleocytosis until I had an expert look at the smear and say, nope, these are not blasts. Because guess what? Acute lymphoblastic leukemia is a very plausible diagnosis that is abrupt in onset and causes liver issues and low platelet issues. But I think the operating hypothesis in real time while you're verifying the data is to go with it and think about what causes a lymphocytic pleocytosis in general. So that's not a situation that we are, as adult physicians, not a situation that we're commonly in, but I'm curious, what is in your library of knowledge for a patient with a lymphocytic pleocytosis?
I think my reflex thinking is kind of like is the same for any elevation in blood lines, like eosinophilia, anything. Is this I guess like primary, like a monoclonal proliferation, or is this reactive, like, or secondary to perhaps to a viral infection, for example? And I think in this patient, given the presentation we've talked to, I'm most concerned of a like monoclonal proliferation. But that's just kind of the simplistic way I think about it.
I don't know. I think it's perfect, my friend, because I'm going to show you something that will, by the way, Tansu and Yusuf, my apologies. You, this is the price that of recruiting the babbly, overly garrulous Rabih to lead this discussion with Maddie. Look at what you said, Maddie. Look, it's right here. Monoclonal versus polyclonal, and that's exactly what you need to do. I'll show you it. This is, by the way, I'm going to show you two schemas, but because I think this is the crux of this case. This is a great way, as you said, of understanding and filtering lymphocytic pleocytosis and committing it to memory. It's not the best way to operationalize this schema because you don't have this data right now. So this schema in the moment is not as useful as the other schema I'm going to show you about how to make progress. But this helps you understand that fundamentally, the question is it monoclonal or polyclonal? We don't ask this question with neutrophilic pleocytosis because neutrophilic pleocytosis is always polyclonal. And that's what funky inflammation does to you. Funky inflammation makes you entertain the possibility the disease is monoclonal. And here you are. I won't go into detail of the causes of the schema because what's actually more helpful in the moment is this schema. I'll put this up here, Maddie. I'm curious, just for you to see. With this in mind, if you had this as a sort of a diagnostic aid and a visual aid while you're thinking about this case, say you like kind of pulled it up, how would this influence your thinking?
Yeah, I think basically how this would influence my thinking is there are like two columns I'm kind of narrowing in on.
Yeah.
The first is if we're saying this is acute, and then I'm looking at the infection category, and she also had a sore throat, and that can be presentation of the EBV and I guess also CMV, but I would expect kind of a more that would happen more in an immunocompromised host, but I could be wrong on that. But I guess if we're saying this is acute, I'm narrowing in on the infection, and that could be consistent with her sore throat that she was reporting. But I think I'm more looking at the subacute to chronic just because I think that's more morbid, and this is not like a slam dunk acute. This is not like a 2-day history. This is a 1 week, and maybe if you asked her more, maybe she had more longer term symptoms. So I think I'm considering the acute infection category with the sore throat in the history, but really want to like rule out or like make sure that we do a thorough workup for the subacute to chronic lymphoma, given the splenomegaly and her lymphocytosis and her the bleeding. And so I'm entertaining both of those, but most concerned about the lymphoma.
Superb. I think that's where your concern should be because most of us view, and most patients with acute mononucleosis have a reassuring and a natural course of spontaneous resolution. In stark contrast, in patients with lymphoma, they need aggressive therapy to improve. So morbidity often, but not always, lies in the subacute to chronic category. And you said exactly what I think one should be doing in this case. Now you go back to the patient and be like, oh, wait, 1 week ago, tell me what your activity level was like. And gosh, that conversation is so powerful because if you hear a almost perfect health defined as close to the patient's baseline, the probability of lymphoma will plummet. But because lymphomas will not begin that abruptly. Leukemias can. And the reason we're entertaining leukemias is because we're open to the lymphocytes actually not being lymphocytes and then being blasts. And that's why leukemia is on our differential, not because it's a good fit for this case, but because we don't want to be fooled by the lymphocytes actually being blasts. So acute lymphoma, highly unusual. Acute leukemia, possible, but only if we're solving the wrong problem. So I agree with you. Gosh, that's my next step, is really have that conversation with the patient. But I'll tell you, I'm a little worried. I'm a little worried because most acute lymphocytosis is infectious mononucleosis, but most infectious mononucleosis does not have a platelet count of 79 and a total bilirubin of 7.2. And that's why I'm worried. And that has me worried and saying, wait, maybe the patient does have a subacute history and a lymphoma, or maybe this is a rare, but important to recognize situation where the patient's developing complications of infectious mononucleosis. So this is certainly a space where not many people have exposure to, and you'd probably have to use analogical reasoning or have been lucky enough to see or heard of a case of complications of EBV or CMV, but this is why we practice. I can tell that you already know what I'm going to ask you, but I'm curious, what complications or issues have you learned about with regard to mono?
Yeah, this is not a space I'm super familiar with, but just kind of a reflex knowledge I feel like I've learned at some point was you can have like, malignancies associated with EBV. So is that potentially at play here? Yeah, and I don't know, maybe like kind of secondary complications, like if you have splenomegaly from EBV and then you have some infarction and, so it's like
Excellent.
steps removed, basically.
We named the most common complication. Awesome.
So yeah, I think EBV-related malignancy, complications of the splenomegaly from EBV. I don't know if you could have some, because I know it causes sore throat, so like complications from that. But I'm not sure.
No, I mean, I think it's amazing how much progress you're able to make in a space that I think a fraction of the world is familiar with.
Splenic rupture. Yeah, I saw that in the chat.
Yeah, exactly. I think that's the thing that people get counseled a lot about. The thrombocytopenia here is a reminder to invoke two complications of EBV. First is massive splenomegaly with possibly a sequestration of platelets, or autoimmune phenomenon. So patients with EBV are vulnerable to autoimmune hemolytic anemia and autoimmune thrombocytopenia. Here, though, the massive depletion of platelet count would have me first worried about massive splenomegaly and the risk of impending splenic rupture. That's the most commonly counseled complication, which is why patients with diagnosed mononucleosis are counseled to avoid contact sports. I had mono. It was rough, and thankfully recovered okay, but I couldn't play soccer for 2 weeks, and so that complication stuck with me. There is, however, along the lines of the category that you opened, Maddie, which is EBV and its overlap with hematological malignancy, is a very important category to recognize because it is very, very morbid. You can have EBV-induced malignancies in two flavors. The first is in adults, as you have commonly seen on VMR, reactivation of EBV driving a cancer, driving a Burkitt lymphoma, or driving a diffuse large B-cell lymphoma. However, you can also have EBV as the primary infectious mononucleosis tumble into a cancer in patients who have occult immunodeficiencies, usually as young adults or children. So EBV-induced lymphoproliferative disease is part of the spectrum of acute infectious mononucleosis. You also can have EBV trigger another kind of hematological catastrophe, which is hemophagocytic lymphohistiocytosis, or HLH. So to summarize, this is a very, very suggestive case of acute mononucleosis if the data is in fact accurate. And there are two pieces of data. Is it actually acute? And is it actually lymphocytes? Both those things could be wrong, and we could be in an entirely different space. But the reason I countered my instinct, and actually, despite Tansu's a brief pause here. I think this is a conversation worth having, that if you recognize this pattern, I would hope that this last conversation also helps you recognize that this is a scenario that is looking complicated. It's looking complicated because the platelets are low, and it's looking complicated because the bilirubin is high, invoking potentially some very scary complications of this very common condition. All right, Tansu, mic to you, please.
So I have the peripheral blood smear, and I saw in the chat, Austin, and maybe a couple other people asked for a, CT of abdomen and pelvis. And yes, the team that was taking care of the patient saw an improvement in her fever and appetite after the start of the antibiotics, but she kept having the right-sided flank pain with tenderness. So in the peripheral blood smear, they saw reactive lymphocytes. And in the CT of abdomen and pelvis to rule out perinephric abscess or pyelonephritis, they saw no evidence of abscess or pyelo, and the CT was notable for a right ureter, minimally dilated, and liver was normal size and homogeneous in appearance. The gallbladder was markedly abnormal with thickened walls and pericholecystic fluid. And the spleen was upper limits of normal in size. The radiologist's impression of the CT was cholecystitis and diseases which can affect the gallbladder secondarily, such as with hepatitis. And a repeat urine culture was obtained, which was sterile after 24 hours. And abdominal ultrasound showed it was positive for a sonographic Murphy sign. And there was also marked thickening of the gallbladder wall. It was appreciated here as well. And the common bile duct was normal in size. There was no suggestion of cholelithiasis or choledocholitis. And there was marked increase in the echogenicity of the wall of the gallbladder, as well as minimal intraluminal fluid that made it difficult to definitively exclude the presence of a small stone. And all in all, it was consistent with cholecystitis. And so I'll take another pause here for you to discuss.
There's so much to discuss here, but I think just to help focus our conversation, I'm curious what knowledge structures you have around that word cholecystitis. What do you know about that space?
Yeah, so I guess cholecystitis is inflammation of the gallbladder. And generally, my understanding of the most common causes is you get, gallstones, and they, cause some, you can have like intermittent, you can have like biliary colic where it intermittently causes obstruction, but it really causes cholecystitis when it like fully causes obstruction, similar to kidney stones. And yeah, that's generally how my simplistic kind of description of my understanding of it. Yeah, I think I'm just trying to think about how to tease out. I guess one quick question, Tansu, do we have I listened to an RLR last night, so I feel like I'm a little bit thinking about that. Do we have a uric acid for this patient by any chance?
No, unfortunately, we don't have the uric acid levels.
Okay. So I think what's standing out to me is the lymphocytes on the peripheral smear, and I'm not quite sure how to tie in the cholecystitis picture into the current presentation. So Rabih, I'm curious how you are thinking of that.
Well, Maddie, I think that if I were in your shoes, I think I would probably be a little bit discombobulated because this case is very complex and very tricky. And I think I actually would lean in on how you seem to be feeling to tell you that actually it's really important that you acknowledge that this is unusual. And that's why I asked you, like, what do you know about cholecystitis? Cholecystitis is often a stone-induced disease in older adults. That's the vast majority of patients with gallbladder issues. And I can tell that this does not strike you as something that you've heard about or read about as a classic presentation of cholecystitis. And I think that's the learning here, This is not classic for acute calculus cholecystitis, in large part because acute calculus cholecystitis is a disease isolated to the gallbladder in otherwise healthy patients. It's very unusual to have gallbladder disease in the context of a systemic syndrome, right? And you have a patient who has sore throat, lymphocytosis, whatnot. So the presence of cholecystitis is usually patient comes in, they go to the surgery, they get operated on, they go home. This is not that. And so I think we have to then try to look up or review what rare, less common circumstances affect the gallbladder. And here we are. You can have a lot of edema affect the gallbladder and syndromes of heart failure mimicking cholecystitis. You can have infiltration of the gallbladder by leukemia, which we've excluded here with the peripheral smear. Or you can have unusual forms of infection in the gallbladder, pus. The most common cause of unusual infections in the gallbladder is called acalculous cholecystitis. And I'm smiling saying this because you presented the cousin of acalculous cholecystitis to Reza and I with COVID-induced ischemic cholangiopathy. Acalculous cholecystitis is basically that. You have stasis and ischemia, not to the bile duct, but to the gallbladder. You can also, believe it or not, have infections that directly infect the gallbladder as part of a hematogenous dissemination to the gallbladder. I think this is most famous in typhoid fever. Maddie, do you know the story of typhoid Mary? Have you heard about anything about this phase?
Vaguely, but I don't know it well.
Yeah, it's basically the notion. So salmonella patients can chronically carry Salmonella typhi in their gallbladder, and the story of typhoid Mary is that this person was infected chronically in their gallbladder, and I think they were working at a restaurant and unfortunately like infected many other people. So the gallbladder can host many infections. It's just very unusual. It's unusual enough that, Maddie, I haven't turned it into a schema, but it's still a list in my Evernote. So let me share that list with you and to see if that list might be helpful. So I'll just pull it up for you.
Will be a schema shortly.
Definitely. But here you are. Salmonella is the most famous. But look at this.
Oh, man. So this is EBV that can have a direct infection of the gallbladder. Is that what you're saying? Yeah.
Yeah, exactly. You saw there's a long list there. But I think if you study the incredible diversity of manifestations of infectious mononucleosis, you realize that like the most common presentation is very, very classic, but the illness script flexibility, what EBV can do to the body is unreal and very, very wide. So here I think the tension, Maddie, is do we ignore the lymphocytes and go with the usual gallbladder? Or do we focus on the lymphocytes and tweak the gallbladder from its common variants to say, hey, maybe the lymphocytes is telling me what's happening in the gallbladder? If you have sort of had to explain to somebody who's just jumping into this case now, which scenario are you favoring? The lymphocytes being the answer and the gallbladder being a tweak of the disease, or the gallbladder being the answer and the lymphocytes being a distractor? Like how would you propose we proceed?
Yeah, I'm a little bit torn actually, but I guess if I had to choose one, I would say the gallbladder, just because my understanding is that this is just such an unusual presentation, like a 15-year-old getting like I guess acalculous cholecystitis, and so I'm really torn actually. I guess I'm leaning, if I'm just going to choose that one, like leaning on the gallbladder, shedding more light on that. However, I'm just really struck by the elevation of the white count, so that's why I'm torn.
Yeah, I think you said it. I think gallbladder disease of the usual variety is super rare in young people. Lymphocytic pleocytosis in a young person, super common. So if you just hold on to that statement and use that to guide your thinking about what's expected and what's surprising. Calculus cholecystitis in a 15-year-old, super rare. Lymphocytic pleocytosis in the context of pharyngitis borderline splenomegaly, not too surprising. So I think I would highlight that sentence that you said, and that's what I would use to proceed thinking.
Thank you both so much. And I think for the sake of time, I think the next aliquot will reveal the diagnosis. So I don't know if you had any final comments or anything, or we can just go ahead and tell you what the final aliquot. Okay, Tansu, back to you.
All right, so the team that was taking care of the patient decided to pursue the approach for exploring what was going on with the gallbladder, and they obtained the HIDA scan that showed excellent hepatic extraction of isotopes. At no time there was visualization of the gallbladder or activity in intestinal tract, and then an ERCP was obtained, which showed no stones, normal biliary flow, but sphincterectomy was performed prophylactically. And then given the uncertainty still about the patient's condition, the surgical consults and the GI consultants decided on performing a laparoscopic cholecystectomy and liver biopsy. After the operation, the patient had 2 bloody bowel movements and severe abdominal and chest pain. She unfortunately had a cardiac arrest and passed away. And autopsy showed there was EBV mononucleosis complicated by acalculous cholecystitis and DIC. And that was the final diagnosis.
Thank you so much, Tansu. This is a very powerful case, and it's very unfortunate ending to the case. Maddie and Robbie, thank you so much for your discussion. I would love to hear your reflections, but before I go to that, I wanted to turn the conversation to a very special guest. A lot of times we have these conversations without the most important person or the people in the room, and that is the patients and their loved ones. As such, I would like to invite Mr. Danberg to go ahead and take the space.
Thank you very much. I'm gonna get screen sharing here. Oh, okay. So
You see
thank you.
perfectly.
You said, can you hear me?
It looks great.
Good. Excuse me. Well, thank you both, Tansu and Youssef, and Maddie and Robbie, for your analysis. You looked at this case from a clinical perspective. I'd like to say a few words about my daughter, Julia Berg, and what my wife and I experienced over the course of this case. Let's see here. There we go. So Julia was a pretty normal 15-year-old. She was entering 10th grade in our local public school international baccalaureate program. She was on the swim team. She'd become an environmental activist. She was alternately charming and challenging, and whip smart, and trying to find her way in this challenging time of adolescence. She experienced depression and was very open about it, and advocated for reduction of the stigma of mental health in young people, and she provided great emotional support to her many friends. The Sentinel event occurred at one of our finest hospitals. It was triggered by a lack of curiosity, overconfidence, and a failure to acknowledge justifiable doubt. Over 6 days in the hospital, one bad decision or assumption led to another, and ultimately to a cascade of mismanaged care, resulting in Julia's death 4 hours following surgery to remove the gallbladder. I think it's important to say that for everything I've just said, the hospital affirms what I've said. I frequently present Julia's case with Dr. Phil Keyboard, who was the chief medical officer at the hospital where Julia died. Thought I'd walk through quickly a brief chronology of the case from our perspective. and try to do this quickly. You know most of the details that started with that nosebleed and the visit to urgent care. The initial diagnosis from the doc at the urgent care was a kidney infection, and provided the antibiotic, which was, we then visited our normal pediatric clinic 2 days later. The antibiotic wasn't doing anything. They gave her a different antibiotic, and we agreed to come back 2 days later, which was the day before we were leaving on a 2-week car trip. At that second visit to the pediatric office, Julia expressed this upper right quadrant pain, and we were referred to the hospital for a CT scan. CT scan took place, and the admitting diagnosis was cholecystitis, and she was admitted to her room at about 1 a.m. on the 5th day, or I guess that was the 6th day. So over 6 days in the hospital. Parade of providers. If the quantity of care correlated with the quality, we'd have been in great shape. But 8 or 10 physicians, nurses, lab techs. It wasn't clear who was in charge. There was no hospitalist identified. As it turns out, our neural pediatrician was on vacation, so there was a different pediatrician from our clinic who was rounding at the hospital. With the tests and labs that you've heard about, there were contradictory comments from the different people who attended Julia during her stay. More than one person actually picked up her chart and said, or mumbled weird, that what they were reading did not make sense clearly. We were anticipating surgery any day. They were waiting for her platelets to stabilize. So for the most part, she was on a liquid diet and nothing by mouth for the last day and a half or so. The ERCP was done the day before scheduled surgery. We went to the adjacent adult hospital where the GI doc performed the ERCP, and he sat down with us after the test and was puzzled. He did not find stones. He did not find what he expected. He did a sphincterotomy, and his conclusion was that she should perhaps not have surgery the next day. And he agreed to have a consultation with the surgeon in the morning. That as it turns out, he consulted with the pediatric gastroenterologist, who in turn consulted with the surgeon, and they decided to go ahead with surgery. 2 hours after surgery, she was in post-op, and they had administered some blood during the surgery, and they ordered more because of the bloody stool, but they returned her to her room on a non-surgical floor, where she died 2 hours later. So the admitting diagnosis, as you heard, was cholecystitis, and you heard the autopsy. Complications of DIC and liver failure due to fulminant Epstein-Barr virus infection. Obviously, the misdiagnosis was mononucleosis. The failure was, I believe that the failure to acknowledge uncertainty caused her medical team to fall into multiple cognitive traps. Premature closure, anchoring. Clearly, the initial admitting diagnosis of cholecystitis was never challenged. Diagnostic momentum, everyone among those 8 or 10 physicians, everyone gave someone else the benefit of the doubt. There was, to our knowledge, no dialogue among them to re-examine the original diagnosis. Overconfidence, clearly confirmation bias. In spite of all those observations that something was weird, everything was interpreted in a way to justify the initial diagnosis. And then ultimately the commission bias, the compulsion to just do something. In spite of the concern of the adult GI doc, they went ahead with surgery, and we know the outcome. Julia's case has been studied and written about extensively, including this article in the journal Diagnosis, which included not only a clinical analysis of the case, but also commentary from Dr. Keyboard, representing the hospital, and my wife and I representing the parents. All patients want certainty, but uncertainty exists, or it clearly exists at the beginning of any clinical encounter. That's where you start. The issues are, how does a physician embrace uncertainty and make the most of it? Take the opportunity to dig deeper, to revisit the history. I think maybe it was one of you said, what was her condition a week before the surgery, or before the nosebleed? That would have been very important. But ultimately you want to reduce the uncertainty, but I'd argue that you should never totally eliminate uncertainty. I think a little uncertainty, which you could also call humility, in the most open shut black and white case, has a place in the diagnostic process. When a patient hears uncertainty, what do they want? What do they want from the physician? They want to know what the possibilities are. What's the most likely possibility? What's the most serious possibility? What are the options for treatment given what we know at that moment? And is there a timeline for finding clarity in the condition? What are the next steps? What should we do in the meantime, the patient and family? And ultimately, or most importantly, reassurance that uncertainty is not sufficient, that you will stay with the case until there is clarity and a course of treatment. My wife and I and our younger daughter Hannah survived the loss, and we remain an intact family. We can't get Julia back, but I can't help but wonder, what if someone on the care team had just called out their uncertainty and revisited the initial diagnosis? I thought about this a lot, and over the course, it's been 18 years now. I've attended a lot of conferences and spoken to a lot of people, and my hope is that we can find a place where every provider leads, above all, with curiosity and humility, where they embrace uncertainty where it exists, where they share that uncertainty and with their peers on the medical team, and where they communicate clearly and honestly with the patient and family, and value their intuition and wisdom. This wasn't the world we encountered in 2005, even though our hospital was known nationally for its commitment to patient safety and transparency. Julia's death was traumatic for the care team, as you might expect. It was a shock for the hospital and actually the entire medical community in Minnesota, in the Twin Cities here. We tell Julia's story in the hopes that it will have an impact and make a difference. I'm part of a world where we call ourselves patient advocates, or advocates for patient safety. There are two kinds of patient engagement that we talk about. One is the first-hand engagement, where it's the patient and the clinician, where they're advocating for their own care and co-producing, if you will, the diagnosis with the physician. I'd like to believe that every patient has the agency to advocate effectively for themselves, but we know that's not the case. And for all sorts of reasons, including culture and language. I talk about there being a place for point of care patient engagement. I think it's the responsibility of the system and the physician to literally take time to coach the patient about asking questions, expressing their concerns, challenging whatever. I think we too often expect patients to come in well-schooled in how to be an effective advocate for themselves. The second type of patient engagement is what I do, and several of us do. We get involved either as advocates or in clinical trials or program design, where we think we have we can make a difference. In most cases, this type of engagement is the result of either a tragic or a heroic medical experience. And I'd argue that there's a third type of patient engagement, which is what I'm doing right now, as a witness and a storyteller. I believe in the power of story, and I often quote Dr. Rabih Taliwal, who has written, "The story, not the statistic, is the brain's preferred unit of learning and its most powerful tool of persuasion." I hope that sharing Julia's story here will persuade you and your colleagues to value uncertainty and doubt as welcome partners in the diagnostic journey. And I again want to thank Youssef and Tansu for setting this up, and I'd be happy to take any questions if we have time for them.
Thank you so much, Mr. Berg. Thank you for sharing your story and Julia's story. This is my second time watch you speak about this, and you are doing the most noble thing that one can do with a situation, which is try to teach others how to work better and do better in the future. Everyone in the chat is sending you their deepest condolences, and they're thanking you. If anybody has any questions, please put them in the chat. In the meantime, I'm going to hand over the space to Tansu, then Maddie and Rabih for reflections.
Thank you so much, Mr. Berg, for your presentation and for your advocacy. I'm sure many of my colleagues here in this room felt the presence of Julia, and thank you for bringing her voice here. Her presence was definitely felt, and your dedication to make a difference in the world by telling her story is so powerful and truly commendable. So thank you so much for that.
Thank you.
Yeah, Mr. Berg, I just want to thank you so much for coming here and for sharing Julia's story. And I think, as you may know, like, tuning into this are so many both early stage trainees and late stage trainees. And I just want you to know that Julia really lives on in your advocacy of her. And I guess, I can only speak for myself, but as kind of on the earlier side, an early stage trainee, it's really impactful to hear stories like the one you told. And, I think in every single case I had the privilege of discussing or seeing, kind of noting this in the back of my mind and acknowledging the uncertainty and all of those kind of important strategies you shared is something that I will continue to take with me. And I hope you know that by sharing Julia's story, I think a lot of people are hearing that message and will hopefully improve, patient care going forward. So thank you so much for your time and for sharing Julia's story. I'm sorry for your loss.
Thank you. Thank you very much.
Mr. Berg, I just wanted to echo what everybody has said already. I think you're a real life hero. I don't use those words lightly. I think my definition of a hero is somebody who's changing the world in such a positive way. And unfortunately, I think it's often in the as a mirror image of tragedy and loss. I think, as some people here know, my path to medicine involved pain that resonates with the pain that you have, although I will immediately acknowledge that the magnitude of it doesn't even compare, I'd imagine. But a similar thread tugged me towards medicine. And the truth is that all of us here are on a lifelong commitment to learn medicine such that Julia's story maybe never repeated again. That's why we all hang out in this space every day for years and years and years. But I think that like anything that is a lifelong struggle, you get tired. And what you've done for me personally today, I can't even begin to share. I think you've poured fuel on a fire that keeps us going. I'm sorry that it's such a tragic, unfortunate way of doing so, but this is one of episode 1100 something, but it is the episode. It is full of learning for sure, but I think more importantly, injects in us the most important ingredient, which is the commitment to keep going. So thank you very much for your time. Thank you for all that you do. We're very, very grateful for it.
Thank you. And if I could say one more thing, I think obviously experiencing something like this is horrible and often results in enormous anger, and I can't deny my anger. But I think I can do this, what we're doing, my wife and I, because the hospital, following this terrible event, was they did the right things. They apologized. They acknowledged the failures. They made immediate changes, and uh, and validated our outrage and our loss in a way that has allowed me to speak on about this. And as I've often said to people, it helps keep me sane.
Yeah. Thank you again. Thank you again and again. I don't think I see any questions in the chat. So I just wanted to thank everyone for being here. Grateful for everyone. Grateful for your curiosity to keep learning. I'm grateful for you, Mr. Berg, and for your patients and patient advocates. Hope you all have a wonderful day and take care.
Thank you very much.